Hello guys and welcome back to my channel. I am Tommy, I'm a human nutrition student and researcher at the university. What I do in this type of videos is to synthesize the classes of the university and then explain and teach you the best and most valuable information you need to know. Today we're going to continue the clinical nutrition series of videos and we're going to take a look at digestive tract diseases and the perioperative care. So let's begin. Digestive tract diseases. We have the hepatic cirrhosis. Difficult to assess nutritionally. There's no protein parameter to follow, no anthropometric data, and no radiographs. Use of branched amino acids to help them. In the cholecystitis, gallbladder stones, removal or conservative treatment with antibiotics. So we can remove it or we can keep it but use antibiotics. Absolute diet, parental if necessary, and if there is no gallbladder, we have to follow low-fat diet. In the pancreatitis, we have the acute one and the chronic. Acute, therapeutic approach depending on severity. Interior with nasogastric or nasojejunal to bypass the pancreas indeed, we get over the problem. Hypercaloric, polymeric or peptide formulas. These are because we cannot really digest effectively everything we eat, so therefore we use those formulas with everything pre-digested. Chronic, alcoholic or biliary due to gallstones, gallbladder stones. Higher prevalence of malnutrition from 70 to 80%. Fractionated, low-fat diet to reduce the pancreatic stimulation. So we eat lower quantities more frequently. Fractionated. And low fat because the fat is more difficult to digest in these cases. Oral supplements if necessary, of course. Inflammatory bowel disease. We have the Crohn's disease and the ulcerative colitis. Crohn's disease depends on what is affected. We have high inflammation here, diarrhea, mucus with blood. We lower the weight, we have fever. We can also have anorexia here, lower intakes and also restriction. These factors, they all cause malnutrition. And we have two types here of Crohn's disease. The stenotic type, when there is a closing of the gastrointestinal tract, which causes bloating and colics. And the fistulae type, so when there is a fistulae in the ileocecal, is most common. Then the colonic fistulae, and then the oesophageal and gastric, which are rare. The ulcerative colitis, depending on the extent and location, it usually has to do with the rectum, of course. So here we have blood and mucus in stool, fever, vomiting, and urge to defecate at all times. Diet, healthy, with fiber and fruit. You have to know that ultra-processed foods have a lot to do with the appearance and occurrence of these diseases. The protein and calorie requirements are very variable. There's no specific diet to these. It doesn't have to be restrictive if it's not necessary. There is an increased risk of lactose intolerance, no insoluble fibers. Intolerance is reversible over time though. So if we correct these, we can go back to normal. And whenever possible, we try to prioritize the oral, then nutritional supplements, and then the enteral and the parenteral nutrition. Diarrhea, acute, when it lasts less than 14 days. For infections and self-limited. The treatment, hydration, antibiotics and diet adjustments. Indeed, it's self-limited, you should really just hydrate yourself. Chronic, more than 30 days due to irritable bowel syndrome and other diseases. So these two can create diarrhea, of course. Treatment, hydration and just the diet, and drugs according to the region of it. On the other hand, constipation, idiopathic causes. Sedentary lifestyle, pharmacological causes, low fiber, poor hydration are correlated to constipation. The treatment is adjusting the diet with 20 to 40 grams of fiber per day. Good hydration and laxative drugs and also movement will help us treating constipation. Short bowel syndrome, we have the inability to maintain a protein energy, water electrolyte or micronutrient balance in the body because there is less surface of the intestine available because a part has been cut off, and therefore the intestinal failure when disability is permanent. We have a higher morbid mortality and a lower quality of life with this syndrome, and the healthcare costs are also high. Types: enterostomy, jejuno-colic or jejuno-ileocolic, which is the best. Phases: acute, we have the water electrolyte losses, and here we have to maintain a nutritional status. Adaptation: intestine learns to absorb nutrients from removed parts. the hyperphagia, increased absorption surface area. So basically, when a part of the intestine is cut off and it is rejoined together, the part that's missing will be replaced by another part that mimics the same absorption and digestion mechanisms of the part that has been cut off. So it's wonderful. I mean, the gut is like the second brain. And then maintenance. We have the good adaptation, specific diet, supplements, and possible enteral nutrition. On the other hand, we can have a chronic intestinal insufficiency. And in those cases, we have a home parenteral, intestinal transplantation, and the use of drugs. Most frequent cause is the palliative neoplasia. They manage the central line themselves when they have the parenteral. And they must have a minimum life expectancy of 2 to 3 months to access the parenteral indeed. Okay, so now let's take a look at the perioperative care and the dietary code. The dietary code is a set of diets available in a hospital center adapted to the physiopathology of the individuals present there. Types basal, which is marked as number 10, all the diets are based on this, and it's about 2200 to 2400 kilocalories, with the macros distributed in 55% of carbs, 30% of fats, and 20% of proteins. And I know that this is not 100%, but that's what the book said. Diets for diabetes, easy chewing. We have diets for dysphagia. We have diets for digestive pathology, astringent, lower residues, high residues, gluten-free diets. For renal insufficiency, lowering potassium, lowering proteins, hemodialysis, and post-operative tolerance as well. Liquid, semi-liquid, semi-soft, easily digestible, the progressive diet indeed. Here the diets are lower in salt. We do not eat as always. There is this thing, the 2-no rule, which basically means that there are 2 foods maximum that you can dislike from the menu. It is indeed a standardized menu for everyone, and it has a mediocre quality due to different tastes indeed. It's not a restaurant. Therapies. We have the abdominal surgery. Malnutrition causes complications, as always, and it is better to wait 10 to 14 days instead of doing this surgery in a malnutrition state. Parameters: lower weight, higher than 10% in 6 months, a body mass index below 18.5, subjective global assessment grade C, and albumin below 3 grams per deciliter. So fast track. The ERAS guidelines have a multimodal rehabilitation system, and it consists of perioperative oral nutrition. So before, during, and after the surgery we have oral way of nutrition. Carb overloading, so no fasting anymore. And no nasogastric tubes. We are fed immediately. Well, not immediately, but right after the surgery. Improvements: lower thirst, lower hunger, lower immunoresistance, and lower anxiety. So multiple benefits indeed. Phased diet after abdominal surgery. Hydrate, we're using water. Liquid, 20 phase 1, using broths. Semi-liquid, 20 phase 2. This is the number in the hospital, number of the diet. Still without prots. And semi-soft, 20 phase 3, with protests but incomplete. And they easily digested the 90, which is complete. So again, here we follow a program of a progressive diet. Gastrectomies, removal of a part of the stomach. Nutritional deficiency, satiety, nausea, iron and vitamin B12, anemia indeed, megaloblastic and ferropenic anemia, exocrine pancreatic insufficiency, and dumping, early dumping, cut off digestion when you swim in the pool after eating, pallor, dizziness, malaise, nausea, late dumping due to hypoglycemia. Takes a little while and it causes palpitations, sweating, weakness, and an increase of insulin. The early one is due to eating too fast, an accumulation of blood in the area. Recommendations: eat slowly, no liquid with meals, no sugars, because they cause dumping, and also the use of acarbose, but it gives flatulence and gas. It was an old drug for diabetes because of the higher insulin. Bread, meat, and milk are not well tolerated. Bariatric surgery, we talked about that in the obesity video. We have the restrictive or tubular sleeve, which causes between 25 and 30% of weight loss. Possible indications for people with a BMI over 45, and the complications are the gastric leakage, reflux disease, and esophageal cancer. Mixed or gastric bypass causes 30 to 35% of weight loss. Possible indications for people with a BMI between 35 and 55. No snacking, reflux metabolic syndrome, and diabetes mellitus 2, type 2. Complications: gastrointestinal stenosis, marginal ulcer, and micronutrient deficits. Malabsorptive or DBP and DBP-CD in disuse. These are not really used anymore, but they were lowering the weight by 35 to 45%. They were indicated for people with a BMI over 45, and they caused malabsorption of fat-soluble vitamins and denutrition, as well as liver disease. Recommendations after bariatric surgery: liquids in lower amounts, protein foods, no alcohol, no sugary drinks, chew slowly, and progressive diets. Post-surgical follow-up, monitoring of nutritional deficiency, bone status, evolution of comorbidities, and the monitoring of regain. Ileostomy. Ileostomy, ileus means intestine, stomia means hole. So it is a hole in the intestine, and liquid with nutrients, they come out. High debit to watch. So we have to take a look at the dehydration here, because it causes renal failure, hypokalemia, hypomagnesemia, hypocalcemia, hyponatremia. So indeed low sodium, calcium, and magnesium and phosphorus. Malabsorption of bile salts, lower B12, very important, and liquid stool. The diet must separate liquids from solids. Eat slowly, no coffee, no spicy, no insoluble fiber. The soluble one helps though, and no condiments. So careful with that, because if not, we're going to dehydrate ourselves, because the liquid is going to come out of the intestine. Diverticulitis. So these are outward excretions from the colon. A lot of outward excretion plus inflammation, they create the diverticulitis. If it explodes, it can create peritonitis, and that's very painful and it can be fatal. Uncomplicated one, well, we suggest a bowel rest, so no eating for a bit, fluid therapy, and dietary progression. If it is a complicated one with fistulas and peritonitis, use the parenteral one, parenteral nutrition. And intestinal fistulae, we have the rupture of the bowel wall due to Crohn's disease, tumors, and so on. So basically it's a rupture of the bowel wall that connects with another tissue. It may be into the vagina or into the bladder. That's a little bit disgusting, because that means that poop goes through the urethra. Types: debit, high, over 500 milliliters, medium, and low, less than 200 milliliters. So medium is between 200 and 500 milliliters. Location can be high, duodenal, mid-duodenal ileum, which is the worst, and low duodenal colon. The intercutaneous is one of the worst as well, because that means that the contents of the intestine are in contact with the skin. Nutritional management. In the medium fistula, we use the parenteral. The medium was this one, the duodenal ileum, which is the worst. Parenteral, replenish what is being lost by vein until the fistula is repaired. In the high fistula, we use the nasoduodenal tube to bypass the duodenum. In the low fistula, we use the oral or interior nutrition with a nasoduodenal tube or a nasogastric tube. If less than 100% of the requirements are met, we use the mixed nutrition with the parenteral, so both the interior and the parenteral, to make sure that we get the 100%. Okay, that's it for this video. Thank you so much for watching. You can find this diagram by clicking in the first link in the description down below and study this diagram very well. Don't forget to like, subscribe, and turn on the notifications, and share this video to your friends and family to spread this knowledge to them as well. Thank you so much for watching, and I will see you in the next one. Ciao!